Something bad can happen. So you could have inducing her when she has barely any blood, I don't know if they replaced her at that time, but her hemoglobin's low, she doesn't have a lot of oxygen carrying capacity, her heart could go into an arrhythmia and she could code. She's a mother of two, not okay, right? So that's important to kind of be thinking about that too. We do things and go lighter on meds and try not to slam them to sleep, but people can still react differently to the medications for sure. We've seen MIs before. There was a couple Bell patients, one that had that MI for Denise years ago in the PACU. And our cath lab's not open 24 hours. That guy's got a STEMI. What are we going to do, right? You're going to code him and you're going to ship him as fast as you can, right? Because he needs to get a balloon pump or go to a cath lab and get opened up. Like, you don't know. Like, again, this 25-year-old guy might have coronary disease from his family, or he looks healthy, but he might not be. So that's important too. So occasionally, what do I see when they insufflate the belly and it makes my butt pucker? I don't like it. What happens? Their heart rate goes from 60 to 40 to 20, and it's like, boop, and I'm like, okay, you either release the insufflation, right? And I'm going to give atropine, right? And occasionally, you got to start doing CPR in this patient because they have no pulse. If we're not compressing their chest, there's no circulation going to any of their vital organs, right? So very important to hop on that. What else can you see that's really scary? What was that? Siler had a pneumothorax years ago too, and it was on a lap pulley. I don't know how that happened, but all of a sudden Tony had it was hard to ventilate, the peak inspiratory pressures were high, end-tidal CO2, O2 stats were kind of dropping. What's going on? Listen bilaterally, no breath sounds on one side, right? So what can they do for that?
Chest tube.
Chest tube or something quicker. If they have a tension pneumothorax, you see it ACLs all the time. The needle decompression, right? Mm-hmm. Yeah, third intercostal space, midclavicular line, put the 18 gauge in there, open it up, get the blood, get the air out of there, right? But that's something that we don't see as much. The ER, of course, sees a lot of these codes. Luckily, we don't have to deal with it as much as other people. Amniotic fluid in the eye, thing I hope to avoid my whole life. A mom upstairs too can happen during a C-section. Chuck, unfortunately, he saw 2 in his career, 3. And I haven't seen cracks long enough, right? Things can happen.
It was on a
But
DNC.
that's all about making sure that we provide the mom, to stabilize her vitals, give her oxygenation. We give an atropine, ondansetron, Toradol kind of mixture of medications because it helps that coagulation cascade and helps with the thrombus up there, or the amniotic fluid in the eye, but that's a whole other topic. But something that you might need to start another IV and we're just resuscitating and giving her a bunch of fluid and managing the mom. So, but usually if you can identify it, they do well. And we've talked about NH stuff too. Let's see, what other situations I think any emergency situation is almost like a code situation. What else can happen in the OR when I'm giving an antibiotic? That's bad news bears. Anaphylactic reaction. Or somebody can have a reaction to my rocuronium. Those are the 2 top medications, muscle relaxants and antibiotics. So the other day I was doing a patient and they had a bronchospasm kind of at the end of the case. I'm not thinking anaphylactic because my rock and ANSEP were up front. I would have noticed that before. No hives, no rash. But we're still gonna, if we need to, we can give epinephrine, ketamine, all the things, albuterol, stuff to open up the lungs. So, what else? Let's see. I think a difficult intubation is an emergency code situation in my world. If we have trouble with intubating, you guys don't see that too often. The glide scope is very wonderful now. I occasionally have somebody who can't ventilate or can't intubate with the glide scope, which is really scary, but that doesn't happen very often. Has anybody ever seen anybody do transtracheal jet ventilation before? Yeah. And Troy's gonna do a whole nother speech about difficult airway stuff, but all that stuff is in that emergency airway kit. We actually be putting a needle through the cricothyroid membrane and ventilating with this transtracheal jet ventilator to help. If I can't get a breathing tube above the glottis, I'm gonna go through that membrane. I'm not doing a cut down trach or anything like that, but it's a way I can oxygenate the patient temporarily until we figure what the heck we can do, right? But a lot of times you'll see even on OB, say you couldn't, on the stat section, you couldn't intubate somebody. Our algorithm goes, we try a couple times, we have the glide scope up there. I cannot intubate, I can put an LMA in. I know they could aspirate. Somebody might be holding cricoid pressure holding. I can technically, I can ventilate them with the mask. That's all I need to do. I gotta oxygenate that mom. It does not matter, if she aspirates, it's gonna be okay, but you
That
can,
jet vent is in the cupboard in OB. So
there's
here-
one up there too,
Yes,
okay,
so
yeah.
here it's in the emergency
Yep.
In the cupboard, it's like on the bottom and it's labeled jet vent there.
Yeah.
If you're circulating that.
Yeah, and it's limited to PSI, we have a manometer, and then we're giving small little breaths, we don't wanna cause any lift-works, but I'm going through a teeny tiny little angio-cap in their cricothyroid membrane, so, that's, hopefully we avoid that as well. And we talked about all the arrhythmias, laryngospasm stuff, of course, bronchospasm too, and what does hypoxia lead to? If I got no oxygenation going to the heart, what happens? Asystole, right? Yeah, and then hopefully they don't die to reverse
Tissue dies.
Yeah, exactly. Tissue dies, they're atherosclerotic, all the dead, their heart's done, and that's our main pump for all these things. We handle our own codes, unlike other areas in the hospital, but we can always, like I said, contact other areas, and you guys know the numbers to call for that, or the overhead, we talked about that before. Always think about positioning you're in. I started lateral, we gotta go back to supine. Say we're on that beanbag for shoulders, like, that's not easy to get good compressions on either, right? We definitely need a backward if we're flipping this patient back to the side. So always kind of think about that first, because these beds are pretty cushioned, and so we really need that backward on there. You can think about different incisions in places like, say you're doing a port or whatever, where you're putting your pads, or if they're working on the breast or something. Just figure it out. Anterior, posterior pads are fine too. You got to find contact to defibrillate them. I don't care if they're having like some reconstruction with Riley or something. You have to be able to defibrillate the patient. Like I said too, just hit on that again. SBAR. I know sometimes we're like, we got to get report from the pre-op nurse, but it is nice that you guys do that face to face. I like that. We're both on the same page. This guy just had a CABG 6 months ago. You know about him. He's an asthmatic. He's got all these allergies. And it's good for you to keep us in check and remember things too. If there's something we forget, hey Jess, remember that guy just had a blood clot in his leg. Maybe this is a pulmonary embolus. Maybe it just dislodged. Like, we are a team. I never think that I can do anything by myself because I always need you guys to help me with stuff. So we go over the rules. We called the code. We did the CPR. We talked about the defibrillator and the pacer. Somebody's recording. And of course, anything we do to assist, and then runners, whether it's labs or you're going to get different things we need, and the medications we talked about too. How does epinephrine work? What's the benefit of giving epi? You guys know the Corticosteroid is a beta-1 stimulant, so it's going to cause inotropy and chronotropy. It's going to help with contractility and your heart rate, right? But it also causes some vasoconstriction, and your beta-2 causes bronchodilation. It's going to open up your lungs. That's why it's good if I'm having a bronchospasm. What's vasopressin used for? How does that help? Some arterial constriction. It's an antidiuretic hormone. So it's going to work on the renal tubules in a different mechanism. And then atropine's an anticholinergic. That's why it increases your heart rate too. So, and you guys know, say I'm just in a case, you know where atropine and robenol are. If I have some